Good evening, everyone. Welcome to the Lung Cancer Living Room, coming to you live from Chicago. Thank you, all of you in the room and those of you who are joining us online. Tonight we're going to be talking about personalizing your lung cancer. What does good look like and why it's important for you to understand what your lung cancer is, because it might be different than the person sitting next to you who has lung cancer. So we're very excited to have our panelists here tonight to talk about what good looks like from A to Z, like I said. So from the diagnostic process, what that means to you, and what that should, I keep saying what that looks like, but how that should go from the moment you're diagnosed through the molecular testing process, treatment options, so on and so forth. So thank you, thank you, thank you. I used to introduce panelists based on their bios and what they'd send me, but rather than reading from a piece of paper, I always find that, you know, I'm like this in the paper trying to read everything about them. I really find it to be more personal and more meaningful to the people watching if they can talk a little bit about themselves and who you are and what you do and why lung cancer is an important thing to you. So Dr. Cedar, do you want to go ahead and start?
Yeah, my name's Chris Cedar. I'm one of the thoracic surgeons at Rush here in Chicago. I've been at Rush for about 5 years now. Prior to that, I did my cardiothoracic training, and prior to that, I did general surgery training. And when I was in general surgery, you know, I really liked the multidisciplinary care of the cancer patient. And I wasn't sure of exactly what that was going to look like or how that was going to play out in my career. And I initially thought I wanted to be a liver and pancreatic surgeon and take out abdominal cancers. And then I saw the inside of the chest. And for me, that was it. And I knew that was where I was supposed to be. And so, you know, I went through all of my training, ended up here in Chicago, and work with a great multidisciplinary team that you know, we on a daily basis are on the phone together, on a daily basis are interacting to give the patients the best care possible and the care that they deserve. And it's extraordinarily fulfilling. Really, you know, it's something that I enjoy doing, and is a ton of fun.
Great, thank you. Dr. Cruiser?
My name is Tim Cruz. I'm a radiation oncologist here at Northwestern in Chicago. I take care of primarily lung cancer patients. My first interaction with oncology came in medical school when I did a laboratory research stint, and I was working, kind of fell into this laboratory situation where I was working with a doctor who was examining molecularly targeted therapies against EGFR and how they interacted with radiation, how tumors became resistant to radiation. So that was my first introduction to cancer, was really in this realm of lung cancer. And since then I did a radiation oncology residency at the University of Wisconsin, and I've been at Northwestern now treating lung cancer patients with some excellent colleagues like Dr. Mohindra for about 3 years now.
Great, thank you. Dr. Mohindra?
Hi, so I am Nisha Mohindra. I am a medical oncologist at Northwestern, and I only specialize in thoracic malignancies. I have an unusual path. So I initially was an electrical engineer by trade, and I focused on optimizing economic systems, and it just took me becoming a patient to understand that that wasn't the path I wanted to take. So I came to medical school and then ultimately got into oncology, and I think especially lung cancer has that nice blend of, you know, leading the field in terms of personalization with targeted therapies, with immunotherapy, chemotherapy, and it hasn't always been the case. And I think that there is a lot of focus on quality of life and patient outcomes, and you know, getting the right people involved early. And it's, you know, nice to have colleagues that now it's, you know, I think pretty standard for us to all talk to each other and say, hey, what do you think? How do we do the best for our patient in their specific situation? So that is why I do it.
That's great. So before we jump into sort of the diagnostic process, what exactly is a multidisciplinary team? And I'm going to pose that to all of you. We've got 3 members of that team, but who else might be on that team, and what does that look like so far as tumor conferences and those conversations?
So at least at our tumor board, it truly is a multidisciplinary team. We have a pathologist there who goes over the biopsy results and if there are any molecular testing that was done, what the results of that is. And then we have our radiation colleagues, thoracic surgeons, and then the medical oncologists. And usually we present a patient's case and ask, as well as a radiologist, to go over imaging. We present the patient's case and ask specific questions, if there are some, about best management.
Great. I think this is important because, again, going back to my initial experience with this with my mom, it wasn't necessarily the case that physicians were talking to one another and having these conferences, or what they call tumor boards, about specific cases so that they could get the opinions from their colleagues based on the different aspects of the disease and what it might look like. So one of the number one things we tell patients all the time is to ensure that they've got a sort of multidisciplinary team looking after their case. So with that, I want to jump into the diagnostic process, which I know for a lot of people watching, you're already way sort of beyond that, but it's important for the people who come back and watch this afterwards, who are maybe newly diagnosed and just entering this realm, to understand what good looks like in the diagnostic phase. So, quite often, and I know you guys know this, patients are misdiagnosed for quite a while. I mean, at least we hear this with things such as asthma, acid reflux, the pneumonia, you name it, right? Why is it so hard to initially diagnose a patient in these types of cases? It's not always. Sometimes it's just there, right? But in a lot of cases, it's difficult. Why is it so difficult to diagnose lung cancer?
Maybe I'll chime in.
Sure.
I think there's a couple reasons for that. Number one, you can't see the lungs, so some cancers present in locations that you can physically see it, in the tongue or mouth, or in other geographic areas of the body that are visible. Mm-hmm. It also gets to the symptoms. The symptoms tend to be vague. So a cough, there's a lot of reasons that someone can present with cough. When someone has a heavy smoking history, we often think this is emphysema related. They've had a cough before, so we might not go right to thinking about lung cancer right away. Likewise, in non-smokers, your suspicion of someone who has a cough who's in a young person who's not a smoker doesn't usually also go to cancer. So we would hope those things would be picked up during a diagnostic workup, but things like a chest x-ray can mimic pneumonia, even when it eventually turns out to be cancer. So there's a lot of reasons why it's hard to cone down on a diagnosis of cancer when someone comes in with a complaint to their primary doctor.
Yeah. So that was the sort of the case with my own mom, was that she had had a chest x-ray, but because of the location in the upper left lobe, it was hiding behind her heart, so it wasn't picked up. And her symptoms were vague. She was having pain kind of radiating across the left side of her chest and down her arms. Everybody automatically went to cardiac issues, which there were coming from the lung cancer, not her actual heart, but so it can be difficult. And I want to touch a little bit on screening again. I know I touch on this in spite of the fact that I know patients are patients and they're already past that point, but there's always an opportunity when you're talking to people to discuss screening as an option for those that qualify. And a few years back, after the National Lung Cancer Screening Trial, we had some data that came out to show that for a certain subset of the population, at least, it was approved to be screened. And to date, less than 4% of those that qualify in this country are actually getting screened. And I think there's an awareness factor. I think there's a fear factor. There's all these things that kind of meld into what that looks like. But as patients and caregivers and advocates, it's an opportunity for you to have these conversations with friends, family members, coworkers that may qualify. And it's anybody over 55, and correct me if I'm wrong, with what they call a 30-pack year history, which is really kind of confusing, but it's either a pack a day for 30 years or 2 packs a day for 15 years, and you have to have quit within less than 15 years, right?
Yeah.
And there's a lot of people living today, like I said, that qualify for this screening, and if we can find lung cancer early, then you can get in to see somebody like Dr. Cedar, hopefully, and have surgery, and maybe some either pre or post-surgical treatment. So with that, the patient's diagnosed with lung cancer. So, Dr. Mahindra, what should happen? You do a biopsy to find out what type of lung cancer maybe somebody has, but what else should happen during that process?
So usually then we do staging. That's where we get imaging and other testing to know where the cancer is. Is it localized? Has it gone outside of the chest? And then that prompts the next set of testing. If it's an advanced cancer, usually one that can't undergo surgical or radiation for curative intent, then we really dive deeper into the biology of the tumor. We look for molecular testing, and we also, in some cases, will do the PD-L1 stain, which I know we'll end up talking about later. So the first step is staging, knowing whether this is a curable cancer or a controllable cancer, and then getting the right people involved.
And then, so we talked a little bit about staging before the molecular testing, and Dr. Cedar, for those patients who qualifies typically for surgery, what stage patients and what does that look like for them?
So there are a number of different stages at which you could qualify for surgery. The most common patients that we operate on are what we call our early stage lung cancer patients. So those are patients with either stage 1 or stage 2 lung cancer. And what that means is stage 1, the tumor is completely confined and small enough, but completely confined to the lung. Stage 2 is typically, once it's gone to some of the lymph nodes inside of the lung, but it's still confined within the lung. As it gets to stage 3, some of the lymph nodes in the middle of the chest are involved, and stage 4 is after it's spread somewhere else in the body. And the most common group that we'll operate on is stage 1 and stage 2 patients, or your early stage lung cancer patients, because we know that those are potentially curable with surgery and sometimes with the addition of radiation, chemotherapy and radiation, or the addition of just chemotherapy. We can cure those patients. And so those are the most common the most common patients that we operate on. I think one of the important things from a surgical standpoint, we talked about staging for a minute, but it's important to, when you're seeing your doctor and you're being worked up for lung cancer, if someone tells you that you're stage 4 or someone tells you that you're stage 3, you want to prove that with tissue, almost always. We tell patients tissue is the issue. And what that means is, and the reason that's important is because particularly here in the Midwest, but anywhere across the country, you could have, beyond a chest x-ray, you could have a CT scan that shows you have enlarged lymph nodes in the middle of your chest. And then you could get a PET scan, and that could show that those lymph nodes light up. All of those things could be cancer. That could mean that it's cancer, but that could also just be a fungal infection in the lymph nodes. Histoplasmosis is very common in the Midwest. In different areas of the country, there's different fungal infections that can mimic that. So we oftentimes see patients coming in from the outside who've been treated at stage 3 or stage 4, and we take a step back at our multidisciplinary tumor board and we discuss it and we say, well, I'm not really sure that's the case. And so, from a patient standpoint, you want to prove what stage you are. And there's multiple ways you can do that. You can prove it with needle biopsies. You can prove it sometimes with surgical biopsies. But no matter how you do it, it should be proven in almost all circumstances, depending on what stage you are.
And how do you determine, you talked a little bit about those patients who might need chemotherapy or radiation or both along with surgery. How do you determine that?
So it's always determined in a multidisciplinary fashion. And what that means is we all sit down, we discuss it, we come up with the best plan. And it will vary reasonable people will have reasonable differences, and you'll see different opinions at tumor board, and we'll talk about it, and then we'll present all of those options to a patient, and then let them make the decision. We see it as our job to help them, give them the information to make that decision. But to get to your question, in a lot of places, if you have lymph nodes in the middle of your chest or stage 3A non-small cell lung cancer, most common type of lung cancer, we'll start with either chemotherapy or chemotherapy and radiation. And if the patient responds well and the cancer doesn't spread anywhere, and the patient looks like they could tolerate a lung surgery after undergoing chemotherapy and radiation, which is no joke, then we would take them to the operating room and potentially cure that cancer.
Great. Okay, so now I want to jump into to treatment options. And we talked a little bit about molecular testing and what it is we're looking for, and we have EGFR and we have ALK and we have ROS1 now, and those drugs that are approved to target those different mutations. And those mutations, very simply put, are what is driving your cancer. So one of our docs referred to it one time as like you're on a bus and the bus driver is EGFR, right? And at some point, maybe the bus driver is no longer going to be EGFR, but it's going to be T790M or something, and we'll talk a little bit about that. But basically, these folks, based on this very, very, very important molecular testing up front, have sort of the benefit of knowing what it is that's driving their cancer, and also the benefit of having an approved therapy to target that. So let's talk a little bit about targeted therapies and the different areas and the first, second, and maybe even third lines in some instances for these patients.
Sure. So I think the best example, or the first real example of targeted therapy in lung cancer was the EGFR mutation. So what we are looking at when we're looking at next generation sequencing or molecular testing is, are we able to identify a mutation in a patient's tumor that is, like you said, driving their cancer? And if so, do we have an agent that can block that signal? So if there's a mutation making this cancer cell grow, do we have drugs that can turn that cell essentially off? And like I said, EGFR was kind of the first one to really come out and really revolutionize lung cancer. And that's where you have a mutation in your epidermal growth factor receptor. So if you think about a cell, your cells have receptors on them that are waiting for signals from the bloodstream to tell a cell what to do. If that is the on-off switch for a cell and it's now stuck in the on position, you need a way to turn it off. What chemo does is it kind of goes after any cell that's dividing quickly, and it's not as specific to a tumor cell. What these targeted drugs are doing are trying to become more specific and actually get to the source of where that signal is coming from. So we started out with the first generation drugs, which included gefitinib, Tarceva, and we've moved into second generation, which has afatinib. And I think the newest thing that changed a couple of years ago was we started to realize that several of these patients were all developing the same resistance mechanism, a new mutation called T790M. And we now have a drug for that. That drug, osimertinib, is now available even in the first line setting. So the field is changing, and this led us to try to dissect that pie of lung cancer even further. So we figured out that this cohort may have EGFR mutations. And now I think we have several molecularly defined cohorts for which we have targeted therapies readily available. I think the challenge is trying to figure out the rest of the pie and continue to identify subsets and then good drugs for those subsets.
Wouldn't it be great if we could harness our own immune systems to figure out what the cancer is, to find it, to attack it, and get rid of it before it turns into cancer, right? And that actually happens in our bodies regularly, right? What is it about the immune system that causes it to, and this is for all of you, to sort of not recognize something at some point And then how are these drugs sort of harnessing that and trying to figure it out?
So your body is built, your immune system is built to look throughout your body and figure out what's normal and what's foreign or abnormal. And it should have checks and balances to get rid of what doesn't look right. And that's how you fight infection. So you would think that your immune system would have the ability to see an early cancer cell and get rid of it. And for most patients or people, that's what happens. But tumors themselves also have tricks up their sleeve and can either express things on their outside of their surfaces or secrete things into their microenvironment, the environment around them, to make the immune system either not see it or not be effective in fighting against that cancer. And so some of these immune drugs are reactivating the immune system to be able to fight a patient's tumor. And I think what we are looking forward to is how to get that to more patients. So it works in a subset of patients, and we're thinking of combinations now. So the newest is to combine chemotherapy and immunotherapy to get more of this immune activation and immune surveillance, as we say. What the newest, I think, thing that you're talking about at AACR was where they combined up front chemotherapy with immunotherapy, and they compared it to chemotherapy alone. And what was interesting was that patients, irrespective of how much their tumor expressed PD-L1, using something to hide, seemed to benefit from using chemo and immuno at the same time. And there are many theories about why, but one that seems to make sense is chemo's allowing your tumor to die off. And as your tumor dies off, those pieces of tumor that get shed into the bloodstream, your immune system has more to know what to go after. It says, that's what that tumor looks like. That's what I should be gearing myself towards. So we're hoping that as we kind of get smarter, we'll start to outthink what these tumors are able to do to our bodies. So the way I look at treatment, if something's working and you're tolerating it, keep it going. You know, if we had infinite numbers of treatments, it would be a different story. But I always say, exhaust the weapons you have. So if it's working and you're doing okay on it, you're tolerating the side effects, I would keep it going for as long as I could. I think Tagrisso was compared, there was data that compared Tagrisso to some of the first generation drugs and had better outcomes in terms of how long people had disease controlled. So I think the patients that started on some of the first generation drugs are now questioning, do I rock the boat or do I stick with what's working? And I think that just comes down to talking to your oncologist and kind of thinking through the scenarios. It's hard as science evolves and we get more information to know what's right for you, because you don't want to miss the train, but at the same time you don't want to rock the boat. So I think it's an important conversation to have and to think about. And like I said, in about half to 60% of patients who are on the first generation drugs may get that T790M mutation that could allow them to also get Tagrisso. But I think that particular question, if I'm reading into it correctly, it's very much a conversation with the oncologist and the patient to figure out. So I think it's got to be right for you.